For centuries, clergy have been intimately involved in caring for the needs of their congregations. Sometimes people turn to clergy with questions about God, existence, or the teachings of their faith tradition. However, for those in distress, seldom are such spiritual or theological questions detached from life circumstances. Grief, anger, sadness, anxiety, loss, worry, relational conflicts. These and many other inevitable life experiences commonly permeate the lives that clergy persons attend to. At times, it may be that some individuals could most benefit from the additional, which is not to say substitutive, attention of a mental health professional. Often, though, collaboration between clergy and mental health providers has not been what it could be. There is no one-size-fits-all approach for how clergy and mental health ought to collaborate, and it is not our intention to summarily dismiss some of the real challenges that do exist. But our hope with this video is to begin to stimulate thinking and provide some signposts pointing toward how these collaborative relationships of care might be improved, so that ultimately these partnerships can build and sustain more comprehensive and nurturing communities of care.
Hello, I'm Father Bill Cantrell, and I serve as Associate Director of Chaplaincy for Mental Health and Chaplaincy and the Department of Veterans Affairs. You are viewing the first of two videos created to encourage your consideration and exploration and to foster discussion between you and your peers regarding how you might, as leaders of faith communities, create and sustain a welcoming spiritual home for those with mental health problems. Through the years that I have served as a parish priest, as a chaplain in the Navy, and in clinical settings, both medical and in mental health, those who have come to me for help come looking for a reason to hope again. For those carrying the burden of mental health problems, much of the suffering presented comes from the silence of not being able to disclose the intensity, frequency, and depth of their anguish to others, without fear of rejection, judgment, impact on their careers, their marriage, or their family. They came to me as a priest. They trusted in the confidence I pledged in my ordination. As of 2012, a study from the National Institute of Mental Health noted a little over 25% of our adult population in the United States suffers from a diagnosable mental health disorder in a given year. That equates to about 50 million people. Many of these people attend our synagogues, churches, temples, and mosques as they seek comfort and spiritual nourishment. The already challenging struggle for those individuals and families dealing with mental health issues only becomes greater when their clergy and faith communities do not understand their dilemma. A basic understanding can open the door for them to enter and get help, and it can reduce the experience of being judged, isolated, or shamed if one was to disclose their story to their faith community leadership. By featuring diverse clergy and lay leadership, including a pastor, a church counselor, a congregational care coordinator, a rabbi, an imam, and a psychiatrist with divinity school training, these videos seek to invite you to consider a variety of perspectives that may be applicable to your faith community.
People like me, psychiatrists and counselors and therapists, are often perceived to exist within healthcare systems. You need insurance or you need some kind of healthcare benefit to go to see someone. It takes making an appointment. And typically when you go in and see a therapist, you're going in to see somebody that you haven't met before, or maybe you've met only through a recommendation. But clergy, you already know because they're already part of your community. Clergy know their communities. They know the people, especially that are regular participants in their communities, and they often have longstanding relationships with people. So you get to know people. You know who they are. You know who their families are. You know what they like and what they don't often. And that's not to say that any clergy ever has the responsibility to know everything about any of his or her congregants, but the clergy tend to have established relationships. So when people start seeming not themselves, when they start seeming more sad than usual, more stressed than usual, maybe more isolating more than usual. When people are going through marital challenges or relationship challenges or problems related to their parents or their children or other family members or others, then often that'll show up and people will seem more stressed and they'll seem more isolated and they'll seem more alone. And sometimes the person will come to a clergy person to ask for counsel. Clergy tell me that people will come to them when things are just not going well in life. Sometimes it doesn't have a clinical term associated with it. It might be that somebody is stressed. It may be that a relationship is breaking down or not going well. It might be that a certain kind of life transition, like someone who's leaving school or going to school or entering a relationship or leaving a relationship, will feel really stressed and alone in that context. If I were to put a clinical label on it, people will go to clergy when they're anxious, when they're depressed, when they're stressed, when they're unsure about which way to go in life and are seeking counsel for that. That's often what people will initially present with. Clergy, like therapists and like physicians, are called to accompany those that are on a journey, to be human beings accompanying other human beings on a journey. And clergy usually do that marvelously well. Don't need mental health professionals like me to step in. But sometimes we all as human beings go through things that are complicated and are challenging, might be based on something going wrong in the body or might not. But clergy begin to think, I'm trying to walk with this person, but I'm not quite sure how to help in this moment. The sadness seems to be too great, or the relationship seemed to be too complicated, or I'm not sure how to help this person without myself getting so caught up in the problems that are going on that I'm losing my own ability to be helpful in this case, or this is affecting the health and life of our community. In that case, when the challenge seems to be pretty substantial, that's what others are for. And specifically, I think that's where mental health professionals, whether it's counselors or therapists or psychiatrists or other physicians or psychologists, can be helpful in joining in and being brought in at that moment. Mental health professionals and clinicians can come alongside those on a journey along with clergy to be able to ensure that people get the kind of help and the kind of support that they need. So also, one special case of that is whenever there's any concern about safety. If someone is talking about suicide, if someone's having thoughts of hurting themselves, if someone has a history of having done things to hurt themselves like cutting or overdosing or more, if someone is making any comments that others might be in danger, whether it's, of course, children or whether it's a partner or a spouse or someone that they might have an ongoing argument with, then I think when safety is involved, I would always encourage more support rather than less from people within the mental health system.
I think people come to, they muster the courage. For some people it comes easier than others to ask for time to talk with a pastor or clergy for lots of different reasons. I think one of the things that seems clear from my pastoral experience is that people will trust you based on their other experiences of you, not in a sort of a conversational posture. So if you greet them or learn their names, they might then take the risk to come see you. But even if you don't have the prior relationship, there's the power of the office, I guess. People have varying ideas about what a pastor is or what clergy are supposed to do. For some people, that's negative, and they've heard stories, or they've had experiences, or the family has sat around the dinner table complaining about the pastor. Those folks are not likely to come to me. But there are many, many others who I think respect the office. And in my upbringing, I didn't think much about the office. But by the office, I mean the fact that this person is in the pastoral office, has that mantle of God's authority. There is a hope in many people that perhaps this person can be of help to me. And so they're willing to take that risk.
I think a lot of Jews turn to clergy or the synagogue when they're suffering for several reasons. One is that they expect to receive an empathic response. Also, to receive what you might call an embrace, a holding, loving context in which to at least stand with their problems, if not explore them. And for many people, they're hoping to get from the rabbi or other clergy guidance. There are particular issues that they're facing, and they want to know what the Jewish approach could be to those problems. And I think some people also come for pretty early on for forgiveness. And by that, I was thinking about people who are having scary thoughts because of their mental health challenges, and destructive and violent thoughts, and whether or not they've sought treatment already or hopefully are about to, the rabbi in the community can reassure them that their illness can be addressed and that they can get to a place where they won't suffer from them as much, and that the fact that they're not acting on them but just having these scary thoughts is something that they don't have to really worry about. And finally, I think some people come to a rabbi as a bridge to mental health services. It's foreign to many people and it's stigmatized. So if the rabbi can normalize it and even describe it in Jewish terms as taking responsibility for yourself, I think that can help a lot of people.
I feel that people turn to clergy because in many people's worldviews, they view that clergy have a direct connection to God. And because of that, there's a trust that's built. If this person is connected to God, and if God is indeed in control of all my affairs, and this person is trying to live a life of righteousness and ethics and morality, then it's logical for me to turn to him or her. And oftentimes, it goes beyond spiritual needs, right? In the Muslim community, for example, 17% of Muslims, when they go for mental health counseling, will go to their imam. So what that does, it puts the spiritual leaders in a position where they better get prepared and better start studying and learning about mental health, and knowing that they're not going to become licensed psychiatrists necessarily. However, they need to build a network.
Most of what I have learned in terms of relational engagement with people with problems did not get its start in seminary. It's come as a result of on-the-job training, if you will, or learning and processing and going to people, trusted counselors, therapists, friends, other pastors, describing in the abstract, what would you do in a situation where somebody comes to you? Somebody might come and speak to me about her mother-in-law. And we end up talking about their marriage, because the real reason she came to talk to me was, yeah, the mother-in-law has been a challenge, but it's the conflict she's having with her husband, the woman's son, where the real issue and tension is. In terms of my own background, I was not trained for any of this. I went to seminary to learn biblical studies, church history, systematic theology, and so there are times when people will come to me and they might have an expectation that I'm trained as a counselor or a therapist, and that's just not the case. I've had the great gift of having others around me with whom I could consult about these things.
So someone who does congregational care is pays attention to the express needs of people in the congregation. If someone stands up and has a prayer request, I encourage there's a team of people, a committee, encourage people to move toward that person and follow up. And just paying attention to needs and pulling alongside people, trying not to solve, but helping them find resources, whether it's prayer or therapy or a small group, folks to pray with, or connecting that person with someone else in the congregation who's had a similar issue. That happens a lot, someone who's grieving over miscarriage. I know of several people who've had miscarriages and have said, I'm willing to talk to that person about how this is affecting her marriage and how this is affecting her physically. And so a lot of it is connecting people who have stories with other people. And of course, when I'm doing it best, I'm actually not doing all the work. It's accessing the resources in our congregation. As program staff, pastoral staff at Blacknell, sometimes we are the first people, someone who might have mental illness or wonder if they need help. These people might come to us first. We might be the first people they tell that they are struggling. Examples of this are wondering if they have symptoms of depression or panic attacks, or have a relationship problem, or have sexual problems, have problems with children. And what we might hear as someone comes in and closes the door is a combination of confession, asking for help, just asking for somebody to listen. Someone comes and is telling us of an issue, and what Alan has taught me to do is pay attention to tears. Instead of assuming I know what the tears are about, I'll ask, what are the tears about? And then just keep following what I hear. I'll ask about, how are you able to function in normal life, or is this impairing you in your job? And it becomes clear during our conversation. I'll go ahead and say, are you wanting to see a professional? And if there are signs, if someone is depressed, I might even ask, you sound really sad. Are you thinking of hurting yourself? If the person has been thinking of this, moving toward a suicide track, there often will be relief that someone has taken them seriously enough to say, wow, you sound really sad. How much have you thought about this, or how have you thought of hurting yourself? And often then that makes it clear, I'm out of my depth. Would you consider, this sounds like a good example for therapy.
Since clergy often are first responders when people are in the midst of life's challenges, it's important for them to be able to honestly assess their strengths, abilities, and limitations if the goal is to provide optimal care to those who are suffering. Knowing when and how to refer to other available resources can be not only a great help to clergy, but also truly offer the best care to those who are suffering and turn to clergy in trust of their wisdom and counsel. When clergy discover the need to refer, this does not mean that they have to forfeit the comforting and redeeming elements that they commonly incorporate into their pastoral and spiritual care, but rather continue to offer them in a manner that clearly reflects their faith traditions and perspectives, in counsel and in the wisdom of their sacred text and in prayer. Clergy have a distinct place in the realm of divine wisdom in addressing the burdens of guilt and shame, offering forgiveness, helping to restore a vision for the possibilities of reconciliation, return, and redemption. However, these distinctive contributions from clergy are not always understood and appreciated by some in the mental health community.
I think there are a number of barriers between mental health professionals and rabbis in collaborating. One of them is that there's a perception that psychologists and social workers, psychiatrists are godless, that they've put in the center of the narrative not the divine or the community or the tradition, but the self, the individual self. And so some people resist the idea of referring to a psychologist or going to a social worker because they feel like it will be supposedly value-free, but actually putting heavy emphasis on the individual and his or her right to do what he or she wants. And so, for example, with couples, I work exclusively with couples in my private practice. With couples, they very often have to get over the idea, many of them don't know that I'm a rabbi and think I'm a social worker. They have to get over the idea that I have no values. I let them know that as an institution, I value marriage and commitment and reliability and all those things. And so I think that the narrative of who's in the center of things or what's in the center is very different or may feel very different from religion and mental health.
A lot of assumptions are made about the way that mental health clinicians are going to engage people who come out of religious communities and for whom religion or religious faith is strongly important. And those can be all kinds of different assumptions, and they may or may not be helpful. Sometimes the assumption is that a psychiatrist or a psychologist is just not going to understand what a strongly faith-based perspective would be like. And there's some evidence that that might be true in some cases. We know from survey research that American psychiatrists on the whole are less religious in their self-identification than the U.S. population as a whole, and even than the group of U.S. physicians as a whole. U.S. psychologists are even less religious than psychiatrists. So there's a disconnect between the religious self-affiliation of at least psychologists and psychiatrists and often the communities that we treat. But it's not necessarily so. The fact that a psychiatrist may not come out of a faith community doesn't mean that he or she isn't deeply sympathetic or can't be deeply sympathetic to the specific kinds of needs of those who are deeply integrated in faith communities and for which faith is deeply important. It just depends. And you can't know apart from clear, straightforward communication on both sides without making assumptions. I speak as a Christian theologian, and I'm pretty aware of how American Christians in the last 100 years have thought about psychiatry and psychology. Always, really from the earliest days of psychiatry and psychology, dating back to Freud and his contemporaries, there have been some pastors that have been deeply appreciative and interested in engaging with whatever was coming down the pike with regard to psychiatry and psychology. In seminaries for most of the 20th century, many clergy were trained in whatever the latest models were in mental health. But there have always been a lot of Christian clergy who've been deeply sympathetic to the mental health professions, who've been eager to work on destigmatizing, who've been eager to collaborate with clinicians, to make referrals, to work on talking about mental health within their congregations. There's also a huge movement, especially within evangelical Christianity, that's been much more skeptical of some forms of psychiatry and psychology. That in part comes from perceptions that Freud himself was against religion, and there's certainly some truth to that. Also, American behaviorism that really gave rise to our modern discipline of psychology was in many ways a way of thinking that wasn't in its initial forms friendly to faith traditions or people of faith. And so there's the perception that psychiatry and psychology are somehow secular disciplines that are somehow opposed in some ways to the goodness of who we are as Christians before God. That itself has different strains associated with it. There's two major strains that really started in the middle part of the 20th century and continue to this day. One strain is what we might call integrationism. And these are people who, Christians who deeply felt that the Bible was to be a source of wisdom, but there was also deep wisdom to be found, especially within clinical psychology. And that continues to this day. So a lot of people who advertise themselves as Christian psychologists continue in that integrationist strain. There's another very large movement called biblical counseling that has different names and different communities associated with it. But this emerged from folks who not only were skeptical of psychology, of secular psychology, but they were also skeptical of these integrationists. They thought, psychology itself is so deeply participates in these secular principles that we really need to get back to the basics. And for some of the earliest and most prominent spokesmen in this field, it was looking at the Bible as a source text for counseling, and the pastor, not the therapist or the psychiatrist or the clinician, as the primary counselor. So pastors often get taught in seminary in some places and in some ways to be somewhat suspicious and skeptical of mental health systems. And then this kind of hits the road when people are in a church context or in a faith community context and someone with serious psychological, emotional challenges presents. How does the pastor then respond? Is it only by looking at Scripture, or is it also by collaborating with different clinical systems? So there's deeply historic structural challenges that sometimes serve as barriers.
Integrating mental health and pastoral care includes both complementary and competing approaches. As mentioned in the beginning of this series, our hope is to prompt thought and conversation about how to best care and support the quarter of our population that suffers from mental health problems. Every story presented to clergy in times of distress presents the challenge of discernment as to where they can contribute through counsel, prayer, forgiveness, comfort, and in the cases where there may be concern of significant mental illness, who they can trust as partners in the care of these children of God. Some clergy have been fortunate to have staff to help in this process, yet most are left to their own assessment. Now let's listen to Dr. Monique Gadsden, a church counselor in Decatur, Georgia.
Upon completion of my master's graduate training, I did not know what to do with everything that I had accomplished in school. So I sat down with my pastor at the time and just told him what I felt my burden was, my call, and if there was anything that I could ever do within the church setting, I was more than willing to assist him wherever needed. He recognized that a lot of his appointments, when people would schedule time with him, were a result of people needing counseling. And he recognized that the majority of his scheduling surrounded issues of counseling. So he did ask if I would be brought on as part of the staff, and if that part of his schedule could be lifted and kind of transferred to me, if you will, it would help eliminate some of the stressors and free up some time for him, and also give him more time to do what he is called to do, and that is study and preach and teach the word. So that's how I came on staff at the church, Beulah Baptist Church in Decatur, where I work now. Been there for 14 years. I'm in a unique situation in that the church is predominantly African American, and specifically as it relates to African American denomination, there has been a history of mistrust when it comes to mental health clinicians. The church is a fairly large church. People would think that my calendar stays full and booked all of the time, but that's not necessarily the case. And that's simply because people are having to become comfortable with seeking out mental health services when mental health services are indeed needed. I do believe that with each individual referral, with each individual encounter, it invites an opportunity to have a larger discussion about what it is that we can do systemically to, again, make mental health issues more normalized, if you will, in the faith community. For example, perhaps it would be a good idea to start a support group ministry within the church so that people who have shared experiences, either it be divorce or grief or veterans who are dealing with PTSD and dealing with re-entry into civilian life, then there becomes this larger community that organizes itself into smaller communities where you can bring about people who have shared experiences. And that can be a place where people feel as though there's a place for me to belong. There's understanding, there is compassion, there is encouragement, which are supposed to be natural byproducts of being a part of a faith community anyway.
As we listen to and consider the stories from our presenters, we discover that not all problems can be solved in an isolated fashion with medication, religious practice, or therapy alone. We find that people who present complex stories often require multifaceted approaches that can involve a combination of pastoral support, other faith community members, family, and perhaps medical or mental health professionals. Some faith communities may have a psychologist, counselor, or nurse on staff, but most do not have such resources. And discernment frequently falls into the hands of clergy alone. Learning a few basic skills to screen for mental health problems could be of great value to clergy, who often are the first and only responders. Taking a little time to develop some fundamental skills can be helpful in determining whether or not a situation warrants professional mental health care.
Clergy are clearly not mental health clinicians. You don't do a standard medical interview when you're interviewing someone as a pastor, and you shouldn't, I think. But there are some basic kinds of things that clergy can be aware of. A few kind of skills that any clergy can pick up that I think would be very helpful as background for the kind of conversations that happen between pastors and parishioners. One would be to, if you haven't done it, to do something that would give a kind of broad exposure to mental health principles, to principles of diagnosis. The model of mental health first aid can be very helpful, or sometimes there's community-based training resources that are open to anyone in the community. So a basic familiarity with psychological language, with the way that diagnosis functions, and with the way that basic kinds of mental health challenges like depression and anxiety and PTSD and bipolar disorder and those function can be very helpful, because the more we know, then the more comfortable a clergy person is going to be in engaging folks that self-identify and say, I'm bipolar, or I live with depression, or I live with schizophrenia or with PTSD. I think a few other things that clergy can know. One is basic principles of assessing for suicide risk and violence risk. As a psychiatrist, I do a lot of conversations with patients around their risk of suicide. And quite frankly, those decisions for me as a psychiatrist are sometimes very challenging. But the basics are not that hard. It's a matter of what we do is we talk with people about their history, about what they're thinking in the present, about different aspects of their life. And we know in psychiatry that certain things like a history of having attempted suicide, like current thoughts of suicide, or especially a current plan for suicide, like a history of abuse or current relational challenges, or current active mental health symptoms, or current gun ownership, or current substance use or intoxication. All of these, along with many others, are risk factors for suicide. If clergy just know those risk factors, as well as know protective factors, of which faith is often a prominent protective factor, and know some of the principles of risk assessment, that can help with those initial conversations when someone's coming in and they're saying, I've been thinking about hurting myself. It can give clergy a little bit more space to be able, not to kind of provide the final assessment, but to be able to know how to talk meaningfully with people about those challenges. In the same way, knowing basic principles of how substance use and substance use disorders work can be helpful. When someone's drinking too much, to know what are the recommended limits above which women and men should not go. And for men, it's 14 drinks a week. For women, it's 7 drinks a week of any form of alcohol. A lot of people exceed that. We find that when people do, they're at much greater risk of losing control over the use of alcohol. Learning kind of the basics of how other kinds of substance use works can be very helpful in knowing the kinds of questions to ask and the kinds of things to begin to recognize when someone is struggling with the use of substances. Around military issues and around issues of military trauma, I think knowing some basics about military culture, knowing the kind of language that people speak, and knowing just how to ask questions that relate to someone's military experience can be very helpful. And that's not really hard to do. And a lot of pastors that are in military-friendly areas have a lot of veterans and military families in their congregation already know those things. But again, the more information, the better, I think, in terms of just providing some basic comfort with having those conversations.
Rabbis need to assess functioning, but beyond questions like, are you working, are you going to school, they have to ask in very artful ways about the quality of a person's sleep or their change in their eating habits, and to do so not in a way that's a checklist like an intake at a medical center, but in a way that expresses interest, curiosity, and really concern. What I think the rabbi can do is to, first of all, not just be interested in what's going wrong, but in getting the whole picture and asking an individual what has helped you in the past with other challenges, what has been of help to you. And not just to ask about depression, but also about the body. Where is it hurting in the body? And build a sense that there are many dimensions to a person, and the hip bone's connected to the thigh bone. They're related to each other. They impact on each other. And that many people, I would even say most people at some point in their life, benefit from support. And I would very much characterize it as support, not as treatment.
I realize it's not my role to diagnose, and that's very important for us as pastoral care people, is we don't have the authority to diagnose. We may have strong clues that someone is depressed. Just taking a look at the person, how the person's dressed. Often I'll ask about, how are you sleeping? How about eating? And, do sort of a very informal depression checklist kind of thing. And if that person has those symptoms, I don't have any qualms about saying, have you thought about, getting some help?
It may be part of our calling and the reason why we choose a profession, and also maybe partly because of what people expect us to be, to solve their problems. And I feel that sometimes we can take that a little too far and have to be really cognizant of our professional limits and boundaries and know that, hey, I can still help this person. The best way to help them or fix their problem is to refer. When people come to seek help, there may be some hidden mental health issues hidden from me. They may know about it or they may not know about it. For example, when Muslims are about to pray, we ritually wash ourselves with water. If somebody has obsessive compulsive disorder, they may start washing themselves for 30, 40 minutes. But they don't realize that this may be a sign of OCD. And that's kind of where the chaplain has to be very in tune with the signs. And if there's classes or trainings that they need to take, then they need to get involved with that. And then understand that there comes a point where we have to stop, pause, and refer. And it's not about me, it's about the service. I think that's really important for aspiring clergy to try to internalize as early as possible.
Often if a person is going through a really difficult time mentally, my tactic has been, whenever possible, is to engage others to help buffer the intensity of the manifestations of the mental illness. An example I can think of is a long-standing member who struggles with bipolar illness. And in that case, we've walked alongside her for many years. And when she was in crisis, we met with her with a team of people. Alan was there, I was there, a wonderful friend who's a retired social worker was there, and then an accountant person. So we formed a team, and over the years that person has gotten better. And now we meet for coffee and celebrations instead of a kind of crisis management. But I think it really works well in congregations to identify who are your resource people who won't be pulled under, who won't be shocked, but who can appropriately come alongside folks who present with symptoms of mental illness.
To identify mental health resources that you would trust, I think there are a few ways. In the Jewish community, there's, in 144 communities in the US and Canada, there's a Jewish Family Service Agency. They have very wonderful professionals and who are increasingly connected to the synagogues. That's a new development over the past 20 years where they know the rabbis and the rabbis know them. So that's one way, is it to really meet with agency people and meet with, and know the lay of the land. I don't know what people call a Rolodex anymore, but to develop a Rolodex of both programs and agencies and individuals who have specialties in whether it's domestic violence or bipolar disorder or whatever challenge people are facing. And then to meet with people and to ask colleagues, Jewish and otherwise, ask other clergy about success stories, who's been particularly skillful and engaging and been able to help people.
Some potential roadblocks that I run into when I want to refer out people who come to me to other services are maybe a lack of therapists, mental health professionals, psychiatrists, psychologists in the area who are culturally competent. And it's very difficult sometimes to ask someone from a different culture to go to someone from a different culture. If you can get to the point where you've convinced them to actually go in, you maybe even walk them or make the reservation with them and they're actually going to go. If the first session is offensive, they may be turned off from the entire service in general. And this has happened. I've referred, or I know Muslim students who have gone to secular counseling opportunities, especially on college campuses, and from the first session, they feel that the counselor is projecting their stereotypes upon the Muslim individual. Maybe they're a Muslim woman who wears a veil, and they're thinking, oh, she must be oppressed, I'm going to liberate her. And she said, what are you talking about? That already comes in from the beginning, and they're walking in like this is not going to work. And I think one of the ways to alleviate that is to provide sensitivity training and diversity consulting to mental health professionals on cultural competency, whether it's spiritual or cultural, whatever it may, or a combination of both.
With some basic assessment tools, clergy can become a more valuable resource to those who turn to them with diverse and sometimes complicated stories. It is important to keep in mind this is not so much to diagnose, categorize, or pigeonhole one story into some neatly organized matrix or process of care, but rather to emphasize the awareness and appreciation that clergy have of the complex whole person, body, mind, and spirit. In a perfect world, we would have at our disposal a vetted list of resources for every possible scenario that is presented to us. But the reality is that it takes work and time to build the trusting relationships in our communities with care providers to whom we can refer and rely upon. Having some basic tools to assess needs and language to communicate with appropriate professionals in clear and informative ways contributes to good progress toward healing and optimal care. Ideally, this care involves ongoing attention from both clergy and mental health professionals.
Another question is when people are actively in treatment. Maybe somebody does have a doctor or a psychiatrist or psychologist or therapist that they're already seeing. And then the question becomes, like, how can the pastor helpfully coordinate with that person? I would say, first of all, that coordination always needs to happen through the person who's seeking help. It should never happen, except for emergency situations, it should never happen without that person's knowledge or consent for a number of reasons, but mainly having to do with the degree to which the person's willing to trust himself or herself to the pastor and to the therapist. If any of us feel like our most deeply vulnerable conversations are not kept in some degree of confidence and can be spread out to anybody, that's going to reduce our willingness to be vulnerable in those spaces. But many people who are seeking help actually want their pastors and their therapists to be in conversation with each other, or at least would welcome that, and certainly don't want there to be the perception that that can't happen. So a number of practical ways that can happen is one, a patient can, or a client can sign a form that gives permission to the healthcare practitioner to be in contact with his or her pastor. That is always appropriate if the person initiates that and has that conversation with a therapist. Sometimes therapists will take a verbal consent in that regard, but anybody in healthcare is going to be very leery of sharing anything confidential about a healthcare situation without the express consent of the person who's in treatment. And that's appropriate. But with the consent, with the blessing of the person who's seeking help, there's no limit to the kinds of conversations that can happen. I think there's some barriers to that. There is, as I said, the perception sometimes that confidentiality should keep those conversations from happening, which is not true. There's also the fact that both pastors and clergy people and clinicians tend to be very busy, and so taking the time to have a phone conversation or a face-to-face conversation is sometimes just hard to arrange, and sometimes that just gets dropped. But there's no reason that it can't happen. But once that's happened, then either the therapist and the clergy person can speak apart from the client or with the client. Sometimes clinicians and therapists would welcome it if pastors actually accompany someone to a therapy session. That may or may not be appropriate, may or may not be too much of an imposition on the pastor's time, and I don't want to suggest that should always be an obligation, but it is sometimes an opportunity. Sometimes there might be opportunities for a therapist to accompany a client to something within the faith community. These are going to be highly individual kinds of situations, but for the most part, the principle of going through the consent of the person who's seeking help in order to ensure that person feels safe to disclose deeply personal information to both pastor and therapist without concern that information is going to then be transmitted to others apart from his or her consent. And also the principle of if people are speaking the same language and communicating with each other, that usually is going to work out best. So for a therapist and a pastor and a person to be all in mutual conversation around what's best and the best way forward is going to reduce the possibility of splitting, reduce the possibility of triangulation. It's going to lead to more helpful community responses. It's going to help the pastor feel more comfortable in providing pastoral care. And overall, the client has people walking with him or her in concert on the journey.
The really important thing is that the rabbi not say, now go there, get this, and don't come back. We should be concerned about how the rabbi will continue to be glue to help somebody both take care of themselves properly and comply with whatever treatment the professionals are suggesting. And again, like the rabbi can be a home base that the person returns to. And in the best of all worlds, there would be a kind of contract, maybe even a written contract, of who's on the team. Okay, there's the Almighty, we know that, but there's also the psychiatrist or the social worker and the spouse and and explore how people are going to talk to each other and what information will be shared for your benefit. Once someone is engaged in a mental health process of exploring their innermost experiences and thoughts, I think the rabbi has a critical role. I think of a few things. One is celebrating. That's something that the mental health professional may not be doing. We need to celebrate growth and name it, and that's why that ongoing Jewish spiritual assessment is important, because it can say, I'm no longer feeling abandoned, but I am feeling sad. Another thing is to reinforce the learning with traditional texts. Let me give you one multi-purpose quote. Hillel, a great rabbi of the first century, is famous for saying, "If I am not for myself, who will be for me? If I'm only for myself, what am I? And if not now, when?" So that's a very compelling quote. It's multi-purpose. I've used it for 1,000 different interactions. But, if I'm not for myself, who will be for me is really powerful for the individual. But if I'm only for myself, what am I? Everybody's mental health depends on service, depends on helping somebody else, even in this simplest random act of kindness. And then finally, if not now, when? That at every moment, you can make an investment in taking care of yourself or in taking care of somebody else.
One of the great joys that I've experienced in working with people in crisis have been when there has been when there is a good synchronicity between myself, the person who's come to see me, and the therapist. We've been a little spoiled in that we have a number of therapists who have come to trust our pastoral work, and we have come to trust their therapeutic work. And with the full permission of the person, we've been together in the same room, therapist, pastor, and patient, and maybe a couple of other people. And that's been a wonderful context for open conversation that has benefited both from the typically longer-term relationship that the pastor has with the congregant and the insights that the therapist can bring. Once I've referred somebody to a therapist, in an ideal world, it doesn't always work out this way. I think my responsibility is to follow up with that person, not to duplicate the therapy or to correct the therapist, not in any way, but to check in with the person and let him or her know that this in no way changes our relationship. I think it really becomes important at that point for me to encourage and support, as opposed to giving a signal like, well, okay, I've washed my hands of you because you're now in the therapist world. I want to be with you to give you support and encouragement, and I mean that in the literal sense, to encourage, to give courage to people to continue to move, because when people are engaged in a therapeutic relationship, that's hard work, that's exhausting work. And they need to know that this is not going to fundamentally affect the relationship that they have with the pastor or the person who's responsible for congregational care, and that there can be really rich rewards for the congregation, not just the individual, but the congregation. Some of our best people in terms of our congregational support system are those who are coming out of their own brokenness and have a story to tell. That gives them credibility that I don't have. In spite of the fact that I have the title of pastor, people are inclined to trust someone who actually can identify with their own pain, with their own circumstances in life.
I believe that the relationship between clergy and people that come to them is eternal. Once it begins, it doesn't end. Even if I refer someone to, let's say, a psychologist in the area, I will tell them that I'm referring you to them for this certain reason. But it doesn't mean that you and I, the relationship that we have going forward, ends today. If you want to come back and connect with me, that's totally fine. If the psychologist wants to call me and ask me for some advice on certain issues relating to Islam, not necessarily about you, but generally about Islamic tradition, I'm willing to do that as well. But I don't want to disclose what you and I have said unless you say that it's okay for me to do so. But I want to make sure that you understand that even though you've moved on to this person for this certain issue, in general, I'm still with you and want to walk that path with you.
There are times while therapy is ongoing with an individual, I will determine that it seems as though the psychological intervention may be running its course, and there may be opportunities for them to be redirected back to the clergy. I do believe that some people may present with, again, that complexity of an issue where there are some things psychologically that they need therapy, some intervention with, and once they have that under control, what ends up happening is it opens up this conversation about, I wonder, why did God allow this, or am I being punished, or is there unforgiveness in my heart, or whatever the case might be. And that's where I take the opportunity to invite them to go back and to speak with the clergy and underscore that that is a theological, spiritual matter, that I feel truly the clergy are best suited to address those issues. I think it communicates that it's not just for one person to do, that there is a need for there to be this disciplined team, if you will, approach to dealing with some of the issues that the individuals bring in, as well as it allows the individual to know that there are different aspects that they're having to deal with as well. It's being able to say, this is a matter that a clinician needs to address, that you need some psychological understanding and/or intervention. And when we get to this place, the clergy will be better suited to address some of the more theological, spiritual matters that you might be wrestling with.
We hope that this video has invited you to think about ways that you and your faith community might improve collaborations with mental health professionals. Some questions we invite you to consider moving forward include: what are the mental health service resources in your community? How do you contact them? What resources are available for persons who may not have financial means or health insurance? How might you establish or improve trusting relationships with those in the mental health community? Consider building upon existing inroads that you may have, or getting together with representatives from key organizations in your community. In what ways might you help your community address some of the stigma around mental health problems and mental health care? As a leader in your congregation, you can set a powerful example for whether and how people receive mental health services.